Good morning, everyone. Welcome to PT on Ice, a daily show. This is Jessica Davis coming at you from Pittsburgh, Pennsylvania. Today I'm going to talk about scoliosis in the adolescent dancer. So this is something that's pretty prevalent in the dance community when you're looking at dancers. So if you look at the research, the statistics for typical scoliosis range up to 5%. But when you compare that to the dance population, it can be as high as 30% in this population. So the question is why? Why are these dancers developing scoliosis? The common misnomer is, well, these dancers are working on posture. There's so much emphasis on bilateral symmetry, so it's unusual. So there's been many theories. One of the theories is that there's a hypermobility contribution to this. There are some that argue that it is associated with the delayed age onset of menarche. And also low body mass index has been associated. So when you look at the literature as a whole, there unfortunately is not enough research, which is pretty classic, unfortunately. And so if we look at just scoliosis in general, first, when you're thinking about diagnosis of scoliosis, you need to differentiate whether this is true idiopathic or non-idiopathic. So that has to be determined first. Imaging is obviously utilized. They do screening with the flexion test, where we do that in screenings. But obviously you need to look at the imaging. So the typical imaging is done AP standing radiograph, and they measure an angle called the Cobb angle. So when you look at that specifically, the Cobb angle, if it falls in the if it's 10 degrees or more, first of all, then that's considered positive. And it's especially if the skeleton is still in that immature state. So what they say is patients who have a curve of more than 20 degrees in that Cobb angle and who are still skeletally immature, those are the patients that are at higher risk of developing some abnormalities as they grow. So in patients who have curves less than 25 degrees, the treatment of choice at this point, as according to various literature, is that they observe these students or patients, and you keep an eye on them every 3 to 6 months. If they fall between that 25 to 45 degree angle, there is some evidence supporting bracing. However, bracing is not, and this is important if you do have a patient who has been assigned a brace, bracing is not useful in actually preventing the curve that is already formed. So it's not corrective. However, it can be associated with preventing the progression of the curve. So that is, however, related to the amount of time that patient will wear the brace. So if they're compliant with it, longer wear of that has been correlated with greater change in the prevention of the curvature development. However, there's some studies when I was looking, there's a lot of studies on how that impacts the student and patient emotionally and psychologically. So there's a lot going on. So different things to consider. So specific to dancers, so this can be an issue, obviously. And then again, back to the treatment, the treatment for the scoliosis too, there's some, of course, evidence out there supporting exercise. But when you look at that, they did a Cochrane review in 2013, and they basically said there really isn't enough strong literature out there to decide one way or the other whether a scoliosis-specific strengthening program has been truly shown to be effective. So basically, as they typically say, we need more studies at this point in time. But there are different methods if you look in terms of treating the scoliosis. But let's talk about the dancers first. So dancers, there's a high prevalence. It's unknown as to why. As I mentioned earlier, there is some theories as that it's possibly due to delayed menarche or that hypermobility presence. But again, that hasn't been validated. And there was a study that was done actually recently in 2017 on the prevalence and predictors of adolescent idiopathic scoliosis in the adolescent dancer. And basically what they said was they found no statistically significance between scoliosis development and hypermobility, age of menarche, low BMI, or hours of dance worked, because all of those have been studied, but according to their findings, they found there's no association that was strong enough to support that. They did determine that, again, dancers are 30% they had a 30% higher prevalence of scoliosis compared to the 3% of the non-dancers in that patient population that they studied. And they found ultimately that 12.4% of those dancers in general were more likely across the whole to have scoliosis versus non-dancers. So again, there's some risk factor, but it is unknown. It hasn't been fully understood. So then it comes to how do we work with a dancer who does have scoliosis? First of all, as with anything, it's important to identify these risk factors early. So if the dancer is young and we determine that they do have a small curvature or a curvature, addressing those impairments early, hopefully theoretically will reduce the presence of that curve as it goes forth or other impairments that they may have. So it's important to address breathing. And then you do your typical examination of a patient in an orthopedic type fashion, looking for various impairments or what other findings you may find, and you deal with those muscular imbalances, whether that is flexibility issues. There's some evidence about asymmetric oblique strengthening, looking at serratus strengthening if there's some scapular winging, and then working again on posture. But when it comes to the dancers specifically, you need to also do your dance screen and look at how they're dancing and look at if there's any other impairments that you may find when they're dancing. So addressing those things and seeing what you can do to get creative and create some exercise regimens that may promote or encourage the rotation in the opposite direction. So I like to do in my treatments, I'll do some sideline PNF exercises, working on incorporation of that curvature in the opposite direction, and work on breathing in conjunction. And I'll do that in sideline and get that kind of neuromuscular re-education. Then I'm going to get my dancer up and standing, and I'm going to work on them in that fashion. So kind of progressive load. And so working on different things such as even carrying a kettlebell on one arm and doing different exercises, so you're promoting like that facilitation or trying to go against that typical curvature. But again, the evidence is unfortunately not very great supporting any of this at this point in time. So when you work with these dancers, it's important to consider those various risk factors and get creative in your exercising. And again, just work on treating these dancers to the best of your ability, identifying these impairments early. So ultimately, considerations, basically just treat the underlying muscle imbalances, work on posture, minimize the deficits as much as you can, work on abdominal strengthening. There was a study that was done looking at comparing core stabilization to just traditional scoliosis exercises. And what they found was the combination of working on specific core stabilization in conjunction with the typical scoliosis exercises was more effective. This was in that study. So again, food for thought, just different things to think about. But again, something that we do see, especially with adolescent dancers, and it's interesting that it's much more prevalent in this population, so something that you have to keep your eye on and look for when you're doing your dancer screening and working with those adolescent dancers. Okay, have a wonderful morning, everyone. Great Tuesday, and make the most of it. Thanks for listening. Oh, and come to my, I'm teaching in Portland in a couple weeks. I can't wait. I'm teaching this course, so Management of the Performing Artist. I can't wait. So come to that. All right, take care. Bye-bye.